Hi, I'm here with another lecture installment, and this is from the recent Hospitalist and Resuscitationist Conference in Montreal, Canada, to which I was invited, and where I gave a talk on IVC collapse physiology. So I start with this quotation from Gattinoni, and it's just to remind everyone that physiology is really important to understand and have some strong premises to understand the caveats that can occur with tests, as hopefully you will see with this talk. So first I start off with this idea of, or this fact that the IVC is an unstressed chamber, and you might be thinking, what on earth does that mean? Well, here on the y-axis we have plotted IVC volume, and on the x-axis is the transmural pressure. So that's the pressure of the central venous pressure, which we'll say is the pressure inside of the IVC, minus the abdominal pressure, which is the pressure outside of the IVC. So if you sort of think of the pressure in the IVC as somebody pulling a door closed, if I'm pulling the door closed at 5 and somebody's outside on the other side of the door pushing the door in at 5, well then the door is actually closing at 10. So that's an important way to think of how the IVC is collapsing or dilating. And this relationship, this exponential relationship, is ubiquitous in the body, right? This compliance curve where you have a relatively large change in volume for a very small change in pressure until you get to an inflection point. And then there's a relatively small change in volume for a large change in pressure. The cranial vault acts like this, the pericardium acts like this, the thorax acts like this, the encapsulated kidneys, the abdomen itself, and as we'll see here, veins. So the entirety of this lecture is based around patients who are breathing spontaneously without any sort of assistance. No PEEP, no BiPAP, no CPAP, nothing, just breathing by themselves. And so if you start off at a relatively low transmural pressure, so a low central venous pressure or a large intra-abdominal pressure, but for the most part, a low central venous pressure, and you take a breath in, when you breathe in, the central venous pressure or right atrial pressure falls instantly, and it falls because it's exposed to the intrathoracic pressure. And as the intrathoracic pressure falls, when your diaphragm contracts, it tends to lower the right atrial pressure. At the exact same time, as the diaphragm contracts and the volume of the abdomen shrinks, the pressure in the abdomen goes up as a function of abdominal compliance. And so this falling CVP and this rising intra-abdominal pressure is like that analogy said, I'm pulling the door closed and somebody's on the outside of the door also pushing it inwards. And you can see when the CVP is low, and you have a decrease in the transmural pressure, a fall in the CVP, a rise in the intra-abdominal pressure, which pushes the pressure this way. On this portion of the curve, you get a large change in volume. And that's what you see with the IVC collapse. So why does the IVC act as an unstressed chamber? Well, in most people, this is my artistic impression of a transverse ultrasound of B-mode ultrasound of the liver with the hepatic veins draining into the IVC. The IVC tends to have a horizontal ellipsoid shape. And so when you increase the volume in the IVC, it tends to grow in the anterior posterior diameter. And it grows in this volume without placing any recoil pressure on the vein itself, which is why you can have this large change in volume with minimal change in pressure up until you get to that inflection point. And so the converse on the flat portion of the IVC compliance curve can be seen here. If you have a relatively high CVP or a low intra-abdominal pressure or both, and then you take a breath in, which lowers the CVP and increases the intra-abdominal pressure, you have to have a really large decrease in the transmural pressure, before you see a change in volume. And so then the question is, well, that's nice. How does this idea of an unstressed chamber and this pressure-volume relationship of the IVC relate to cardiac function? How does it relate to the clinical questions that I ask at the bedside? And those are often, what is the patient's volume status and whether or not the patient will respond to intravenous fluids, which I'll call volume responsiveness. And those are two very different things, and they can diverge. So don't confuse the two. And the way that we can make this relationship, I think, a nice model is the Guytonian one, where we can take the central venous pressure and we can infer something about the cardiac state. So this is the Guytonian primer, and this dot here is very important. This is the right atrial pressure, or the central venous pressure, barring any cable obstruction. And so that relates to those previous slides that we've seen in terms of a high versus a low right atrial pressure. I won't get into too much about it, but your volume status lies at this x-intercept point here. Then this dark blue line is the venous return curve. So as right atrial pressure on the x-axis falls, venous return increases, and so does cardiac output. And this light blue curve is the Frank-Starling curve. And when they lay on top of each other, you get this operating point for the cardiovascular system, which defines the right atrial pressure, which is here slightly less than 5 millimeters of mercury, and the cardiac output, which is on the y-axis. So as I mentioned, the y-axis is volume or flow, so that's venous return or cardiac function. They have to equal each other in a steady state. And on the x-axis, we have the right atrial pressure, which determines your cardiac output at that moment. So the example that I gave when I was giving the talk was I was standing on stage, and unbeknownst to me, I had a monster clot in my superficial femoral vein just waiting. And this is me in my steady state. Let's say I'm relatively euvolemic. I have a mean systemic filling pressure of, should be about 10, maybe I'm a little hypervolemic. And I've got a relatively normal cardiac function. And so my venous return curve is intersecting the ascending portion of my Starling curve. So this is volume responsiveness, whether or not increasing the right atrial pressure will increase your cardiac output on the y-axis. And this is your volume status. And so this is me standing up giving the talk. And then that first clot flies off from my leg, and it gets stuck in a segmental pulmonary artery. And my cardiac function starts to get angry. So that means the cardiac function curve shifts down to the right. And what you see is an increase in the right atrial pressure. So it started here, and it increased along the x-axis because the impedance to flow from the right ventricle is high. And then I continue my talk, and the next clot flies off. And what that does is it increases the right atrial pressure as my cardiac function curve is impaired. Again, my volume status hasn't changed, but my cardiac function is taking a hit as these clots continue to fly. Now, what would normally happen is there'd be a compensatory release in adrenergic tone, and that adrenergic tone would decrease the capacitance of the venous bed, so there'd be a slight increase in my venous return curve. The mean systemic filling pressure would shift to the right, and that adrenergic tone would also act on my heart, which would tend to shift the cardiac function curve up and to the left to try and defend cardiac output, because that would increase cardiac output on the y-axis. But for argument's sake, let's say that I don't have any adrenergic response to these showering clots. And then the next clot comes, and you can see that I'm in big trouble here. I'm in shock. My cardiac output is almost zero. My venous return and cardiac output is almost zero. And what you start to see here is that the right atrial pressure, the CVP, is slowly approaching my mean systemic filling pressure. And what I think is occurring there, it relates to venous Doppler, which is an emerging technique that intensivists are starting to do, which is talked about quite a bit at the hospitalist and resuscitationist conference. As the right atrial pressure gets closer and closer to the mean systemic filling pressure, the right atrial pressure waveform that we're all familiar with, the A wave, the X descent, the V wave, the Y descent, the CVP, you can physically see that in the Doppler tracing. And as the right atrial pressure gets closer and closer to your mean systemic filling pressure, that CVP waveform that you see in the venous Doppler should get more and more distal. Normally you see that venous Doppler tracing of the CVP waveform, which is the S and the D wave, in the hepatic veins only. But as the right atrial pressure starts to rise and it moves closer to the mean systemic filling pressure, what I think starts to happen is then you start to see it in the portal veins and you get portal vein pulsatility. It starts to go further down and you start to see it in the renal veins and you get renal vein pulsatility. And so rather than venous Doppler being a marker of volume status, because in this situation you can see that my volume status hasn't changed at all, but I should have very pulsatile venous velocity because of my impaired cardiac function. What it's telling you is that cardiac efficiency is poor, and cardiac efficiency is defined by Parkin and Pinsky as the distance from the right atrial pressure to the mean systemic filling pressure relative to the mean systemic filling pressure. In other words, it's telling you, cardiac efficiency is telling you how close the right atrial pressure is getting to the mean systemic filling pressure, or it's also telling you the slope of the cardiac function curve, because if the right atrial pressure is getting very close to the mean systemic filling pressure, you know that the slope of the curve of the cardiac function curve is being impaired. So I may post on this shortly, but my approach to venous pulsation in progressively more distal veins is that it's a marker of poor cardiac efficiency, and I'll return to this a little bit later. So I'm standing there, and then the final clot goes, and it's now I've got this massive, completely obstructive saddle embolus, and I die. My cardiac output stops, blood in my low compliance arteries falls down to my venous capacitance beds, all the pressures in my circulatory system equilibrate, and they all fall out at the mean systemic filling pressure, which, as I mentioned before, is directly proportional to your volume status. And so I'm lying there dead from this massive pulmonary embolus, and then Josh Farkas, who is in the front row listening to my talk, realizes what's happened. He sees jugular venous distension, realizes that I've had a pulmonary embolus, and he gives me a whopper dose of TPA, lyses the clot immediately, and then my cardiac function returns, and my right atrial pressure falls. As cardiac function returns, venous return improves, and then I've got a normal cardiac output again. So that's your Guytonian primer. Another very important in the Guyton curve is this idea of pleural pressure, and the pleural pressure is the x-intercept of the cardiac function curve. So this changes as I breathe. So as I breathe in and intrathoracic pressure falls, pleural pressure falls, the curve will shift to the left, and as I increase intrathoracic pressure, it shifts to the right. So here I breathe in, and you can see the pleural pressure falls, cardiac function pressure, cardiac function curve shifts to the left, and what happens to the right atrial pressure is it moves up. So as I breathe in, I'm pulling preload in, so venous return and cardiac output increase, but the right atrial pressure falls onto this very important portion of the venous return curve, and it's this maximal venous flow. And this is when a Starling resistor occurs, and a Starling resistor occurs when the pressure inside the tube falls below the pressure outside of the tube, and what that does is it causes collapse. It doesn't stop flow, it leads to a maximal flow. There's collapse, and then it instantly reopens, and then it collapses, and then it instantly reopens. But that's what's occurred here. This is a Starling resistor, and this is the collapse of the IVC. And so you can see that there is some tenuous relationship between your volume responsiveness, or whether or not you're on the ascending portion of the curve, and when you hit that Starling resistor physiology. So let's go back to our baseline and see what happens if you give me a bolus of crystalloid. And as I mentioned, that would increase your venous blood volume, so that would push your mean systemic filling pressure rightwards, increase your venous return curve, and so your right atrial pressure would rise, and so too would my cardiac output, because I was on the ascending portion of my Starling curve. So I was volume responsive. So in this situation, I breathed in, I had a collapsing IVC, and you said, oh, he must be volume responsive. So I give him some fluids, and I predicted a true positive, right? Now in this situation, after I've received the volume challenge and I breathe in, my right atrial pressure falls, but it doesn't get to my Starling resistor physiology, so my IVC doesn't collapse. And you've predicted that you've increased my volume status, and now I am much less volume responsive. So that was, let's say, a true positive. So the first is that the venous return curve doesn't change with inspiration, which it probably does a little bit as the lung volume increases. And the other key assumption is that that Starling resistor physiology here, the maximal flow, occurs at atmospheric pressure. We also assume that the cardiac function doesn't change, and that the change in the pleural pressure, that decrease in the x-intercept here, the cardiac function curve, is standardized. So let's talk a little bit about the specificity of IVC collapse, and that's a measure of the number of false positives. So when do you get IVC collapse? When a patient is actually not fluid responsive. So as we mentioned, there were some basic assumptions previously that we were running on, and that was the venous return curve doesn't change, and that the Starling resistor physiology occurs at atmospheric pressure. But what if we added PEEP to a patient? So what the application of PEEP does, or CPAP, is it increases the mean systemic filling pressure because it recruits venous blood into the stressed volume. There's probably a few other mechanisms, including reflex changes, and increase in intra-abdominal pressure. But it does increase the pressure head for venous return. One of the key things, though, is that it also increases the critical collapsing pressure. So as we mentioned, this Starling resistor physiology normally occurs at atmospheric pressure, but with the pressurization of the upper abdomen, the collapse physiology actually occurs at a higher intraluminal pressure. So instead of 0 here now it may collapse at a CVP or a right atrial pressure of 7 or 8. So collapse becomes more readily. I think you could probably see that that's going to lead to some false positives. So if nothing were to change to the cardiac function curve, now this patient would still be volume responsive, and you'd be seeing collapse at a higher pressure, a higher right atrial pressure. Remember, the collapse occurred at atmospheric pressure before. Now collapse is occurring anything below 6 or 7 millimeters of mercury. And that's that critical collapse pressure that we talked about. The other assumption is that cardiac function doesn't change. So let's say if in this particular patient, this patient was a little hypovolemic, they had high West zone 1, West zone 2 fraction in their lungs, and that the increase in the intrathoracic, or in the airway pressure increases the fraction of West zone 1 and West zone 2 physiology. And what that does is it shifts the cardiac function curve down and to the right. So it's afterload of the right ventricle. As you saw it, because of the increase in the pleural pressure from the PEEP, so the airway pressure is quote-unquote transmitted to the pleural pressure. It's not really transmitted, it's just the fraction of the airway pressure that's required to lift the chest wall also rises. So the cardiac function curve itself shifts rightwards. And so now you've got a patient who's got a slightly lower cardiac output. It fell, but I would argue now that this patient is fluid unresponsive, right? Increasing the venous return curve to the right would lead to little or no increase in cardiac output. But this patient's on CPAP, so now when they trigger the breath, so this is end expiration, now when they breathe in, they can actually hit the Starling resistor physiology more readily because of the pressurization of the abdomen, and you actually can see some collapse here even though this patient is volume unresponsive. So that would be a false positive, and that would lower your specificity. So as I showed in the conference, this is a non-scientific summation of scatter plots for the 4 main studies that looked at IVC collapse and fluid responsiveness in spontaneously breathing patients. So these are the 4 key ones. There's another one by Coral in 2012, but it didn't have a scatter plot, so I left it out. So again, in this situation, specificity, you would expect there to be few false positives. So this IVC collapse up here, 90% collapsibility and 0% collapsibility down here, you'd expect there to be few scatterers up here. Okay, because what I'm going to show you here are true non-responders. These are patients that don't respond to fluid. So if they were collapsing, you would think that they would. That would be a false positive. So you want as few up here as possible. As I mentioned, if a patient had pressurized upper abdomen from, say, PEEP or auto PEEP or intra-abdominal hypertension from whatever the cause, you would expect there to be a large number of scatterers up here because there'd be a lot of false positives. You'd see collapsibility when they're actually true non-responders. But in each of these 4 studies, patients on mechanical assistance were excluded. That's a key point, is that these patients did not have or were at least at low risk for upper abdominal pressurization. So when you scatter them, you can see that the majority of patients who are non-responders actually did have a dilated IVC. And so it depends on where you draw the cutoff, obviously, but if you sort of draw it in the collapsibility of 35 to 45%, you probably get a specificity of about 80%, which means that you've got about a 20% false positive rate. It's fascinating because when you look at studies of using CVP to detect volume responsiveness, a CVP of 0 to 5 has historically had a specificity in about the 20 to 25% range. So this data actually lies on top of each other pretty well. Again, all of these studies excluded patients at risk for upper abdominal pressurization because they excluded patients receiving mechanical assistance. So that was specificity. Let's talk about sensitivity. So there's lots of reasons why there could be false positives, and there's lots of reasons why there could be false negatives too, which would impair your sensitivity. And I'll just focus on only one of those mechanisms here. So one of the basic assumptions here is that the change in pleural pressure is standardized. So there's the pleural pressure on the cardiac function curve. So if you just we'll say this patient truly is volume responsive. If you shifted the venous return curve rightwards, they would increase their cardiac output. But they kind of did a baby breath in. You wouldn't hit that Starling resistor curve physiology, the max venous return Starling resistor physiology. So you would not see collapse of the IVC, even though this patient is a true responder. So that would impair your sensitivity. That would give you a false negative. False negatives lower your sensitivity. So again, let's look at those 4 studies and look at the sensitivity of them all. And if you were really collecting true positives, you'd expect all of the dots to be clustered up here because a small IVC should detect true responders. And again, these are only the responders. And when I scatter plot them all, just by eyeballing it, looking at the various papers, you can see it's actually quite poor. Sensitivity, you can't really draw a line in the sand here, saying that above which these are true positives, below which these are true negatives. So based on the above, how could you improve the specificity and sensitivity of IVC collapse for determining volume responsiveness is a key question. So 1, to improve specificity, exclude patients receiving ventilation assistance. So that would lower the risk of upper abdominal pressurization, lower the risk of that false positive collapse. And all of those studies did. So they had probably, I'm thinking, hypothetically, I can't prove it, but I think just based on physiology, you've got ideal specificity situations. But as I mentioned previously, if they kind of don't give a great inspiratory effort, you could run the risk of impairing your sensitivity, which is exactly what you saw. So here's the 2 of them lined up next to each other. So you can see if you take this 40% collapsibility rate and take that to the bedside, if you look at patients with higher than 40% collapsibility, there's going to be some false positives because of the specificity, but there's going to be many more true positives than false positives. So collapsibility is actually, in patients who are not ventilated at low risk for intra-abdominal hypertension, is a more meaningful clinical finding. If you see kind of a fixed dilated IVC, you kind of don't really know if they're a responder or a non-responder. So these are those 4 trials. So Prue and colleagues in 2017, what they came up with was a standardized inspiratory effort. And so they made sure that all the patients lowered their intrathoracic pressure to an adequate degree. And these blue ones here represent the patients in their 2017 study that did not have a standardized decrease in intrathoracic pressure. But in 2018, they published another trial where they did, and I'm going to overlay them here. And you can see that when these patients had a manometer placed at their lips and ensured that they decreased their intrathoracic pressure during the inspiration, that the sensitivity did improve somewhat. And so we're getting to the situation where, like inspiratory dilation of IVC in paralyzed patients on the ventilator under extremely standardized situations, you can improve the sensitivity and specificity of IVC collapse under extremely standardized conditions. What are those standardized conditions in all of these studies? The patients are not receiving any ventilatory assistance, no CPAP, no BiPAP, no nothing, and they have a standardized decrease in intrathoracic pressure. So one of the last things that I wanted to talk about was relating back to that idea of using venous Doppler. So at the beginning of the lecture, I mentioned that idea of detecting a decreased cardiac efficiency. So again, this is completely unproven. It's based only on physiology. One way of potentially sussing out a responder from a non-responder with a dilated IVC would be to look for portal vein pulsatility. And as I mentioned before, so portal vein pulsatility also has its own caveats and its own false positives that I won't get into. But as I mentioned before, if pulsatility reflects a right atrial pressure that's getting closer to the mean systemic filling pressure, you may infer that cardiac efficiency is impaired. And if cardiac efficiency is impaired, it is probably more likely that you're on the flat portion of the Starling curve. So if you had a patient with a big fixed dilated IVC and you didn't know they were a fluid responder or non-responder, and one patient had a pulsatile portal vein, it may be more likely that that patient has poor cardiac efficiency, and therefore that patient is actually a true non-responder. So the dilated IVC with the portal vein pulsatility actually lies in here. Whereas if you had a patient with a dilated IVC without portal vein pulsatility, it suggests that the cardiac efficiency might actually be adequate, and that might actually be one of these responders with a dilated IVC. Again, completely conjecture. So the take-homes here, in patients at low risk for upper abdominal pressurization, so they don't have PEEP, no auto PEEP, no ascites, no intra-abdominal hypertension, no obesity, then IVC collapse has decent specificity, and it completely mirrors what was seen with CVP data. In patients without standardized inspiratory effort, a dilated IVC is unhelpful in predicting a cardiac response to volume. And again, as I mentioned, potentially one way of determining a true non-responder from a true responder with a dilated IVC would be looking for pulsatility in distal veins, in the portal vein and the renal vein, etc. Thanks for listening.